TOA community, welcome back everybody. Robert Linkle, trainingtheolderadult.com. We are going to dive in today and talk a little anatomy. Eventually we're going to get into the knee and discuss the knee specifically and how it's going to move about in the mechanics of physical activity. And this is kind of piggybacking on a talk I did recently on the importance of lower body strength, specifically as we age, and understanding that the stronger our legs are, the more capable we're going to be to sit to stand, to walk, transition our gait, stay on our feet, reduce our risk of falls, ultimately keeping a higher quality of life, okay? So if we look at levers of the body, the first class lever that you're going to have, a good example is our head. Our head, the fulcrum is going to be in the middle, okay, where our neck is. The load is going to be kind of the front side of our face. The majority of the skull is placed to the front side from the center fulcrum. And then the effort is going to be the musculatures based off the occipital protuberance, a little bony part on the back of your head, levator scapulae, trapezius, etc., where when they engage, they're going to pull your head back up or they're going to eccentrically lower it back down. So fulcrum to load working, in the center. The next one is going to be a class 2, and the primary class 2 lever in your body is your foot and your ankle. I believe there's one more. I think the scapula technically has a class 2 component to it, but the ankle here is basically the best example. And this is the wheelbarrow example, that the load is going to be in the center, the fulcrum is going to be at the front, so the wheel of the wheelbarrow. And then we pull up on the handles, the load's going to be in the middle. Your gastroc, your calves, soleus, gastrocnemius are going to plantar flex, pull the foot up, the heel up, the fulcrum at the front of the toe, okay? And then you have class 3. Class 3 is going to be kind of this hinge mechanic at the elbow, and it's going to show the fulcrum basically in line or at the back of the mechanic and the movement arm, and then the muscular efforts inside the fulcrum, and the load is at a rather distal end of it. Some other examples or ways to kind of present this shows you the force and load with the arrows, okay, class 1, 2, and 3, and you can kind of see those as they go down. That first one kind of being the teeter-totter, the second one being more of the wheelbarrow, and then the third one is where the bicep or the hamstring or our mechanical advantage is going to come in through musculature, is going to be very important at these third classes. Not that it's not as important on the others, but there's, I guess I would say, more mechanical advantage to take advantage of inertia or the manipulation of the mass and the load, where with these class 3s, if you don't have the muscle mass to move it, it's just not going to work. So I've got some mechanical examples there for you. When we look at that class 3, the knee, there's a challenge going on at the knee here that I like to use an example for the quadriceps specifically. The origin of the quadricep up at the hip, you have 3 quadriceps that are going to originate below the hip at the top of the humerus, and then you have one that's going to go above it, your rectus femoris. So the rectus femoris is a hip flexor. The other 3, vastus, medialis, intermedius, and lateralis, are all simply quad extensors. But all 4 quadriceps are going to reach over the top of the kneecap, beyond the kneecap, and insert on the anterior aspect of the tibia. So if you can imagine the difficulty for the quadricep to try to pull the leg up, as in you're holding an air conditioning unit and you have to reach out a window and then hand it out to the person outside. Basically that heavy load and then the long reach and the exposure of your back, that's basically kind of the same mechanical advantage that the quadriceps have, reaching over the top of the patella, and then they have to lower that weight down out in front of them. It's extremely challenging. They are not at a mechanical advantage as opposed to the hamstrings that are on the inside. And that's where you're going to see that class 3 lever action come in, where you have 3 hamstrings, biceps femoris, semimembranosus, semitendinosus. And then you also have your gastrocnemius, which is another knee flexor. And we also have one extra, let me bring up my picture of that guy real quick. We have one extra one here called the popliteus, and that's one additional, it's not a ton of support, but it's one extra knee flexor. So technically you have 4-ish, 5 knee flexors, 3 hamstrings, 1 gastrocnemius. Now you have the soleus as well, but the soleus does not cross the knee joint. It's based at the top of the tibia and the fibula. So it's only going to do plantar flexion. It's not going to help in knee flexion. And then you have the popliteus is on there as well. All of those are working inside the mechanical hinge of the joint. So it's going to be a lot easier for them to act. And this is where in most cases you'll see people, myself as a good example, where we have more quad development than hamstring development because of the actions we do on our day-to-day, but also the quad activation. You need more muscle mass to be able to work against this mechanical disadvantage, right? To be able to manipulate our leg and move it. Where with the hamstrings and the gastroc and the popliteus, it's 5 musculatures. Again, not all of them super big, but still 5 different muscles that are going to work against the 4 quadriceps on the other side, and they have the mechanical advantage on the inside of the knee. So because they have a better advantage and they have more numbers, they don't need to be as big in mass. Now, ideally, if we want to keep a really healthy hip and a healthy knee, those musculatures should be developed and trained and worked on as well. But you don't have to be 50-50 at the leg or at the knee in that terms of musculature. It'd be great if you were, but you can get away with 60-40, even in some cases 70-30. But a lot of overdevelopment on one end and underdevelopment on the other often is going to lead to some type of injury in the future. So emphasizing and placing some developmental strength on both sides of the knee, quad side, anterior, hamstring side, posterior is going to be pretty vital, okay? Now, as we continue to look at the knee and zoom in here a little bit, we're looking dead on. This is, if I'm looking straight at someone's anatomy, someone standing here, anatomical position, this is their right knee. How do we know that? The fibula on the outside of the leg, okay? So I've got the tibia right down the middle, fibula's on the outside of the leg. Now, in the center is your floating bone, the patella. The patella is independent and literally kind of floats in space there. I'll show you a side view in just a second, where the quadriceps all insert on that patella. And then the patellar tendon is going to then reach over the front of the knee and insert on the tibial side. And some will call that the patellar ligament, some will call it the patellar tendon. Technically, when you're dealing with a tendon, you're going from a bone to, from a muscle to a bone. In this case, we're going from bone to bone, so it's often referred to as a patellar ligament. Tomato, tomato, in this case, they kind of overlap, and there is at some point, and it's up to debate, some will suggest there's a separation between the two. It doesn't matter. Point is you're going to have origins insertions that are going to stabilize the kneecap and hopefully keep it in good alignment and in good space as the knee will continue to flex. Now, on the medial side of the knee, in this picture, the far side over here, if you can see my thumb this side, that's the medial side of the knee, your medial collateral ligament, or your MCL. The lateral side, the other side, you have your LCL. The front side of the knee is your ACL, your anterior cruciate ligament, and the posterior cruciate ligament is in the back. On either side, we have meniscus, medial meniscus, lateral meniscus. And the meniscus is kind of designed to create and take cushion, impact, okay, blow. And that's going to have some damage and some manipulation done to it in different ways. I'm going to show you a very cool photo here in just a second that shows all the damage that can be done to the meniscus. But if you take a mushroom and dice it, cut it in straight lines, right? Like you have a mushroom that you rip off the bottom, so it's just the top of the mushroom, and then you cut, and then you turn all those on their side. That's kind of what a meniscus looks like, is one of those carved pieces out of the center. I'll show you in just a second. In these pictures, they're nice and round, they're perfect little saucers, but they don't look exactly like that in real life. That's a little bit more of a drawing, okay? Here's a side view, give you a little bit better idea. You see how that patella is kind of floating there. That patellar ligament / tendon is going to be, kind of connecting that quadricep tendon onto the patellar tendon ideally, and then the patellar ligament is then going to continue down and insert. You see the density and the squishiness of the meniscus and how big that LCL, the lateral collateral ligament, and how big and thick the anterior cruciate ligaments are. You can see those views from here. They're pretty significant. And when you feel or manipulate your knee, you can feel these structures in your knee. But you can also see, and what I wanted to have you kind of get an idea between these two is how the kneecap is, and the knee itself is kind of encompassed on all sides. And you can see where if one of these is damaged, how much instability it would then create at this joint in particular. So we've got to kind of do a little bit of everything we can to protect this from impact on the meniscus, okay, to any kind of twisting or shearing forces that are going to push or pull or twist or turn on the knee and tax any of the collateral ligaments or any of the crucial ligaments. And then in terms of forward and back displacement, how fast moment arm is going to manipulate or move the joints. It's just, there's a lot to consider and a lot to think about. And then you have all these potentials of injury that can occur to the meniscus, where you could tear an ACL and an MCL, an LCL, or a PCL. You can completely tear them, you can partially tear them. Some can be repaired and sewn back together. Others have to be basically removed and have a replacement part put in, which, especially with the ACL, it's very cool, this process. I'll do my best to explain it, but let's talk about the meniscus here really quick. You can see where longitudinal, radial, and horizontal, all of those kind of have that like sliced mushroom, right? Slice, take the middle, take it out of there and turn it. You can kind of see that mushroomy component to this, right? So a longitudinal tear right down the meaty part, a radial tear is from that inside aspect up, or a horizontal tear, any kind of like moon shape or carve in there. Then you have a bucket handle where basically the center has continued to tear further. So it's a longitudinal tear that's expanded. And then your radial parrot break, it's where the tear, the radial head, that radial tear is going to continue and extend up. And then with the horizontal, you have a flap. So basically it's starting to kind of peel open as it comes apart there. All of those are different results based on different movement patterns or injuries. Some can occur if you are sheared or twisted or pulled. A lot of meniscus injuries will happen with football players where they'll have their foot planted and someone's got them wrapped up or held around their tibia, and then someone pushes them back the other direction or twists them away, but their leg is fixed. And you'll see a lot of tears, especially the radial and the horizontal components will come from that. So these are, it's a great image. I give credit to Dr. Caleb Burgess there for his post here. And then Knee Pain Aid is an awesome Instagram page. I really like, they've got and put up great stuff, especially images like this that just help teach this so well. There's a lot that can occur about this knee in those different areas, but it doesn't mean if you tear that, like life is over. Oh, I've got a torn meniscus, I just can't go on with life. That's not the case. The knee is rather resilient, and your body will find a way, if you will, to carry on. Unless like 2 or more of them are severely damaged, then the knee is just not going to work very well. It can do okay without one, but as soon as 2 or more are damaged, we're in bad shape. So let's talk about something really quick called the unhappy triad. The unhappy triad is the medial meniscus torn, the ACL, anterior cruciate ligament torn, and the medial collateral ligament torn. Now, if you looked at all of those from a side view, I know this is on the lateral side, but if you kind of looked at it from this view and on the other side, they all kind of stem and have a connecting point, okay, where it's the meniscus, the ACL, and the MCL all kind of branch from a very similar origin and work about the knee, the medial side of the knee, where if there's I believe it's a planted foot and an external rotation of the femur, all 3 of those can be torn and damaged. And that it occurs often enough that it's got this name, the unhappy triad, meaning that all 3 are damaged on kind of a regular basis due to those types of injuries, okay? That's a big one and a common one that you're going to be out 9 to 18 months to rehabilitate. This used to be anything other than a meniscus repair to the knee was at least a year until basically Adrian Peterson from the Vikings was able to rehab an ACL injury in about 9 months and get back to playing full contact football. And that criteria that he used to rehabilitate kind of became regular practice then. And now most people can get back in 9 to 12 months from an ACL tear. So what they now do with an ACL tear, which is really, really cool, is they will cut into the top of the patellar tendon, the quadricep tendon at the top. They'll cut into the meat, right where my cursor is there. They'll cut into the meat, and they will go right down the center of that tendon through the patella, okay? And then down through the patellar ligament and into the bone of the tibia. And they'll basically just cut a channel right out of the center of that whole thing, okay? Now with the bony part, they're not like with a knife cutting it, they're drilling right through the whole thing. And the drill is hollow. So imagine like you have a piece of drywall and you want to plug your TV in through the wall, right? So you get one of those drill bits where it's hollow in the middle and you just drill a hole in the wall and it just pops out a little piece, okay? And so you have like this little pizza table hole that you can then put your cords into and run them down the wall and plug them in on the other end, right? It's basically a drill like that, but it's long. And so they drill, again, I'm giving you very rough analogies. This is not my area of expertise. I just observed this. So they drill down through the top of the patellar ligament, through the patella, down through the patellar tendon, and then into the tibia. And then they pull that whole thing out, and then they kind of sew back together any of those meaty parts that they just damaged. And they allow all that to regrow, but they now have a piece of tendony bone, and then ligament through the center, and then tendony bone on the other end. And they can basically use that and run it through the rear aspect of the femur, through the front to the tibia, and replace your ACL with a chunk of your patella, basically. And then those two bony meaty ends will grow into the bone because it's your own bone. And now you have a piece of your patellar ligament is now, in many cases, stronger than your ACL was originally. And then you just have to rehabilitate back the strength and structure of this and the injury that, what they drilled out and such. It's very, very cool. I just saw, rough drawings of how this is done. But it's very neat to see that they can use their own parts. Because what they used to do is flip the leg around, and right at the base of the back of the knee, they would take a chunk of your hamstring as it kind of led into the inserting ligament, the inserting tendon. And they would take that out, a chunk of that out, and use that to rebuild your knee. But then that left the hamstring rather weakened, 20, maybe 30, even 40% weaker than had they just left it alone. Where if they can take parts of your bone and your ligaments here, this can be either regrown or just lived without, as you have plenty of mass there and meat and bone to support your knee just fine. But now you're using something that's either equal strength, if not greater, to rebuild this component of the knee, and it's all your own parts, as opposed to taking a cadaver ACL or something like that and building it back into the knee. So from the unhappy triad to the meniscus repairs to an ACL repair, PCL repair, all of these, unfortunately, we've had lots of opportunities with our clients, and also a very, very close, adopted nephew of mine who just blew his knee apart last year playing football. PCL, ACL, MCL, all meniscus, everything except for the lateral cruciate ligament, I believe. Everything else was torn. They've had to completely rebuild his knee, and he's now, a year and a half into rehab, hopefully and eventually going to get back onto the field here. We will see, but it's been a major repair and a major rehab for him to get back to the point where he's going to be able to place contact, plant, turn, and maybe even take impact and be hit on there, okay? This mechanical joint is so vulnerable, and it is very capable of producing great movement patterns. We just need to take a lot of care in thinking about preserving and taking care of the knee. And the elbow is a hinge joint class 3 as well. It doesn't have as much stress put through it as we don't walk on our hands, we walk on our legs. And so the knee is going to take a lot more stress. That's why the musculature around it is usually much bigger and much greater. Also, you don't have a patella in your elbow, so you're not having to worry about anything that floats around or a massive mechanical disadvantage. But the structures of these hinge joints are very, very similar. A couple of these images that you're seeing here now, I'll give a shout out to Frederick Delvari, I don't know how to say his last name, but I own all 4 editions of this book. I absolutely love it. And it just gets into greater and greater detail with every one of these that he does. If you have a mind's eye for fitness, I think there's no better way to learn anatomy than, and that's cool. That's the picture I'm about to show you right there, is my favorite version of a deadlift / squat, and how to train about the knee here. And I was showing you the popliteus earlier. These are little images, grabs, if you will, from his book. And I find it so easy to learn anatomy and to adapt the musculatures involved in the other anatomy about a joint like the knee, everything we just zoomed in on. When you have a visual like this, where you go, oh, I can relate it to something I know really well. We do dumbbell squats like this often with our knees wide. And by going wider, I see that I get my adductor engagement, the quads are gonna get work. And because of this high angle and the depth, I'm gonna get some medial and upper glute, and I'll get some activation there. My postural positions are going to dictate a lot to this. Like the drawing of it and the application of it to this lift that we can relate, it helps you in your mind's eye visualize those musculatures and see them through that action and go, yeah, I can relate this to my mind now and remember it. Different than, here's my anatomical chart of a body standing palms up, down at the side. Now, from that position, when the knee does extension and the knee does flexion, what exactly occurs? Well, it's a little easier for me to relate this to a quad extension machine and a hamstring curl machine rather than standing, bringing my heel to my butt and bringing it back down. Both are the same actions and both involve the same musculatures, right? It's the same thing that we're talking about. It's just, how am I going to relate it to my brain, to my memory, to make it stay so I can call on this information when I need it? When I can plug in an exercise or a lift like this and then think about quad extension, knee extension, what's happening there, quadricep, 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 origins, insertions, actions, etc., as opposed to the anatomical standing body and then moving from there. There's nothing wrong with learning either way. This just really helps me connect it to my profession and helps me retain it a lot better. So this is a little bit of a preview, if you will, of how we are going to learn our in-depth anatomy for fitness this coming fall. We have an entire course that's going to be built around all the musculatures and the major moving parts, just like this, of the human body. And this, 25 plus minutes here has been focused just on the knee. We are going to do this at the ankle, the hip, and the back, and the elbow, and the shoulder, and the wrist, etc., and work our way through all the major moving parts and the compound / complex movement patterns to make sure everybody has a really good understanding of this, but they can relate it to our profession, to our actions, and just help bring that to memory. And now whenever a client comes in and goes, I've got an ACL injury, I have a meniscus injury, when I squat or when I step up, I feel this instability, and right away you can go to these images and you can go, boom, okay, the ACL, what does that look like from the side? Okay, I can see when they do a step down, what kind of pressure that's gonna put at the knee, I can get that. And then, all right, when I get into that deep squat, what kind of angle and stretch am I gonna get? Like it just helps you connect and troubleshoot and discuss and understand this anatomy. So when I hear other coaches say anatomy is not that important, you don't need to have a huge understanding of it, I completely disagree. I think you need to have a really good understanding of it, but I think there's a way to learn it that just makes it stick into your brain where you can recall this information and transfer it to your client so they have a really good understanding of what you're talking about. And then when you start to discuss programming and strategy for how to overcome and assist their limitations, either partnered with their physical therapist, or if this is just a weak musculature we're talking about, we can take care of that on our own. But if they're overcoming a meniscus tear, an ACL, or something along those lines, yeah, we partner with the physical therapist to make sure we know what we're doing and they're in good hands, and the PT will work with us on what we should and shouldn't do. But eventually, PT is going to end, and they're going to be our responsibility. And so we need to have a really good understanding of this. And having a giant book like this that you can recall and go into whatever movement pattern, whatever lift is going to be. I mean, he's got hundreds of them in here, and great explanation and details all around the world of fitness. It's not just a general anatomy book, it's a fitness anatomy book. And that's what's going to help us recall and retain that information like that, okay, as soon as we need it. All right, I hope you've enjoyed this. I hope you got some good information and some good takeaways and have a better understanding of the knee and exactly what we want to be able to do anatomically at the knee when working through a flexion extension type movement, like a squat, like a deadlift, like a quad extension, like a hamstring curl. Understanding the anatomy underneath will just help carry over into the movement pattern itself and how we can troubleshoot any discomfort, any problematic responses that our clients are getting, and go, okay, when you're doing your quad extension and the front of your knee kind of hurts, well, if we dorsiflex, right, and tighten some anterior tib and gastroc up to allow both sides of the fulcrum to work a little more efficiently, does that take the pain away? And they go, yeah, I don't even feel it now. And you go, boom, okay, I needed to understand that. That's the depth that we want to go to with this, where you're going to be able to troubleshoot these types of limitations. All right, gang. Any questions, hit me up down below. If not, continue to fight your good fight against sarcopenia. We'll see you in the next one. Peace.